I often tell my patients you need the right patient with the right condition to see the right doctor, to have the right treatment to get the right results.
Podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The affirmation does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website or podcast. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derek Davis, a fellow physician specializing in pain management. In this episode, we speak about lower back pain with Dr. Oluseun Olufade, also known as Dr. O or Dr. Alfy to his patients. One could simply sum up Dr. Olufade by saying role model. He has the characteristics that come most readily to mind when one thinks of a doctor. He cares deeply about his patients, he volunteers in the community, and he's as sharp as a scalpel and dresses equally as so. Additionally, he currently serves as the team physician for many of the sports teams in Atlanta, Georgia. Dr. O went to Rutgers University for undergraduate, then Robert Wood Johnson for medical school. He did his residency at Temple University in physical medicine and rehabilitation. Then he completed 2 fellowships, the first at Temple in pain medicine, and then another at Crozer Keystone in sports medicine. Lower back pain is extraordinarily common. It affects over 100 million Americans and disables more than 5 million. In fact, many of the people watching or listening to this episode are probably experiencing it right now. Sorry. I intend to have many conversations about lower back pain in the future, but I'm very lucky to have discussed it first with Dr. Olufade. As always, thank you so much for watching or listening, and I hope you enjoy this episode and learn something. Dr. Olufade, thank you so much for coming on the show. Welcome to World of Pain MD. I really appreciate your time, sir.
Thank you, Derek. Thanks for having me.
Yeah, of course. So I just actually kind of want to get started here and kind of understand what led you to get both a fellowship in interventional spine and pain and in sports medicine.
So my initial thought is I wanted to make sure I had all the tools, so to say, in the bag in treating a patient. I think one of the good things about healthcare is I think is one of the best in the world. But one of the limitations of it is more of this segregation or kind of specifics of, I joke around and say, if you do the right shoulder, some people do the left shoulder. So there's so much separation and specialization is actually the word I'm looking for. So when I see a patient, I want to make sure I have all the things to kind of treat a patient. Oftentimes also there's a lot of correlation, meaning hip causing back pain, neck causing shoulder pain. I wanted to feel very comfortable treating it. I wanted to be a one-stop shop. I wanted to be a guy that treats all the non-surgical injuries or pathologies or pain that somebody might have, to the extent that if I can treat it for the most part, it's something that I think is surgical and should be surgically treated. So that's kind of the reason why I did those fellowships.
Got it. Okay, awesome. Thank you very much. It almost makes me think about, and I think I've discussed this with you as well about, pursuing another fellowship, but I suppose we can talk about that another time. So in your clinic, what is the most common cause of lower back pain, or some of the most common cause of lower back pain that you see?
I think it depends on the population we're talking about. People will often say the most common type of low back pain is non-specific. It's muscle strain, it's muscle sprain. And that happens. But by the time they get to your office, oftentimes the severity of the condition is a little bit higher. So in a younger person, for example, an athlete, by the time they get to me, is it a disc herniation or spondylolysis, which is a stress fracture on the back? In a middle-aged person, it's more likely a disc herniation. In an older population, it's more lumbar stenosis, which is the narrowing of the canal in the back, or oftentimes we'll call lumbar facet arthropathy, which is just arthritis of the back. So it also depends on the timeline of when they come to see a patient, as well as the demographics, younger, middle-aged, athlete, active or not active, or even sometimes what type of sport or activity they engage in.
Got it. That makes sense. Are there certain populations, demographics that you see more affected by lower back pain? I know that, as we get older, that can affect you, but are there particular ones? And I know you deal with a lot with athletes as well, but do you see a common theme in the patients that come to your clinic?
So there's a range of people. Like I mentioned, sports. If you play sports, you probably have, depending on what literature you read, 2 to 3 times more likelihood of having an injury. So let's say you compare a 15-year-old gymnast versus a 15-year-old girl or boy. The gymnast is more likely twice and sometimes 3 times more likely to have back injury. So sports is one of the risk factors.
Sure.
The other one is pregnancy. Yeah. As you get, as women get pregnant and gets the center of gravity changes a little bit, it gets a pull on the back. More likely to have SI joint pain, as well as lumbar radiculitis or radiculopathy. As we get older as well, you definitely have an older population. History of trauma, motor vehicle collision, or recent history of those are probably some of the risk factors that I see that predispose somebody to having back pain.
Gotcha. Okay. Are there lifestyle factors that affect back pain?
100%. Yeah. So when you start mentioning the lifestyle, obviously depending on what type of activities you perform. So if you're a very active person that does a lot of deadlifts, a lot of heavy squats, that will play a role. Depending on what your lifestyle is in terms of what type of food you eat. Pro-inflammatory versus anti-inflammatory food, metabolic syndrome. Like we mentioned with pregnant women, the same thing can happen in a man as well too. If you have your center of gravity or body habits change, you tend to lean forward a little bit. That would predispose you to back pain as well.
And you mentioned the inflammatory diet, and I know that's kind of a hot topic. A lot of people probably ask you about that as well. What do you usually recommend to patients and to people in terms of diets that are pro-inflammatory versus maybe helpful for inflammation?
I often say a lot of diet fads have come and gone. Yeah. And the reality is most of them, when it's gone, we realize it's not working as well. Right. What I say is just apply some common sense. I think it's been studied that carbohydrates more likely to give you more increased inflammation. Yep. We know that fried food more likely to give you one. We know that a lot of tomato sauce or barbecued food or pizza, it's more likely to give you those. Yeah. So I think when you start from that moderation about don't eat too much of that, limit it, that's one angle. Got it. The other is we know we have natural antioxidants, avocado, nuts, depending on what kind of oil that you use, we know those ones are actually things that could calm down the inflammation. So to answer your question directly, what I've seen, or the proof has been mostly with Mediterranean diet. The population that's lived the longest in this world, the blue zone area, they're actually more like the Mediterranean diet. So, and I've done it personally as well too, and I've seen the results. Yeah. So to answer your question, if people say what kind of diet, I give them those basic information. Yeah. But Mediterranean diet, just because of the variety of the vegetables and the color and the pyramid, the type of food, the amount of food, that's the one I usually go to.
So do you have any strategies you give to patients in terms of preventing back pain? They come to you, they've done some physical therapy, maybe you've done a trial of naproxen, some oral steroids, and back pain's better, they see you. And do you give them preventative strategies thereafter?
Well, I often ask my patients, what do you do for work? What do you do for living? What are your chores? Part of the reason why I ask that question is to get to know them. But the other reason why I ask that question is try to talk to them about the different strategies that they could do to not come back and see me. Yeah. So, people joke around, and it's been said that sitting is the new smoking in some ways. So oftentimes if somebody sits down for 8-10 hours a day, get a standing desk. If they sit a lot, every time you answer a phone call, make sure you stand up to take the phone call before you sit down. So that's more from a sedentary standpoint. Yeah, yeah. As we all get wiser and more mature, I tell my patients, not older, there's certain type of exercises you want to do. So for example, if you have a disc herniation, it's not a good idea to be doing crunches because as we will get to in a little bit, things like crunches, heavy deadlifts, heavy squats can make your symptoms worse. If you're going to even do the deadlifts and squats in moderation, making sure you're not trying to max out, making sure you get in the good form, get in the good amount of repetition, Those are the things that I kind of encourage folks of middle age that kind of want us to continue to participate. In the older population, I just tell them, keep walking. Don't stop. Keep moving. The more you move, the more endorphins you have, the less pain you have as a result of the endorphins, the less weight you gain, the more calories you burn. So just motion, movement is often sometimes what I encourage the older population that I see.
Absolutely. Yeah, that really aligns with, our specialty too, physical medicine rehabilitation, regarding movement and the rehab elements of movement and getting people back on their feet and with function, basically. What would you say in terms of how lower back pain affects mental health and physical well-being?
Yeah, I think that's one of the key things, or one of the ways I try to empower my patients. The reality is, when people have back pain, there's about 30% of them, they're going to have recurrent low back pain for the rest of their lives. And it comes to a point where if they're not able to carry the kids, if they're not able to do the stuff they want to do and they like to do, it starts to affect them psychologically. What I try to do is find that fine line, almost like the border of what you're able to do, what you're capable of doing. Sure, you might not be able to run, but you could do some biking, you could do some hiking. So I think being able to encourage them, in spite of the chronic low back pain that you have, finding that strategy to kind of find a sweet spot that you could do whatever activities that you want to do. I think that's essentially important, and try to encourage them to do that.
There is about, probably more now, because I think this statistic is from 2022, 5 million people disabled from lower back pain. And I was just going to get your thoughts on the growing contribution of healthcare costs and disability stemming from lower back pain.
I think one of the risk factors, one of the higher risk factors to suggest if somebody is going to apply for disability or be in disability are several things. One is if they're not satisfied with their job. That's one of it. The second is if they have a previous history of some kind of motor vehicle collision or trauma or injury that potentially could have medical legal components. That's another part. So I think that's one basket to talk about.
Sure.
And the other basket to talk about is just the chronicity of pain. I often tell my patients, especially when they have chronic pain, that unfortunately, low back pain is similar more to diabetes, hypercholesterolemia, more than it's similar to a rotator cuff patient that I see versus a meniscus versus an ACL. There's a little bit of chronicity that it goes with. So I think it's just setting that expectation, understanding that this is not a one and done. I think we might be having a few conversations in the future, just setting that expectation. So disability is real. Disability exists. I think it's because of the chronic nature of the condition. I think what I encourage, just like we said earlier, is you got to keep moving.
Yeah.
Because once you stop moving, the condition gets worse.
Yeah.
I think just what I would encourage, or what I would recommend, at least a good portion is, yes, if you can't lift weights, find maybe a job that you could sit down with. If you can't sit for too much, find a job that you could do a combination of the two. But once you kind of get on disability, the studies suggest, and I'm not suggesting that's everybody, the studies suggest that you're less likely to get out of it. So finding that work, job regiment, or maybe a setup to kind of still allow you to keep going, it's the best thing.
Right, you're absolutely right. There is a big association with the length of time you're off of work due to back pain and the being less likely to return to work thereafter. And I think that's pretty sad statistic, but it's pretty consistent. Are there common misconceptions about lower back pain you see, that you hear from patients that often you try to correct or educate people about?
One of the ones that I get a lot is, I should be using the back brace, doc, right? How many, is it okay to use it? I often tell my patients, for short term, it's okay to use it. Long term, or mid, or more like for chronic, subacute, couple of months, or else you have a diagnosis of maybe a bad spondy or something, or significant facet arthropathy with a fusion, which is simply said a lot of arthritis in your back that we need to calm down, or you have a fracture of the transverse process, or you have significant scoliosis that you're trying to maybe try try a little bit of time or brace. I always recommend it, but long-term brace use is not ideal, and maybe we shouldn't do too much of that. I mentioned a little earlier about, doc, my back pain has been going on for a few months. Now what? Just letting them know there's a little bit of a chronicity to it that will occur in at least 20 to 30% of the population, and just educating them on that.
Is there someone that you see that you wish would have come earlier to clinic? That is to say, are there things that should alert a patient, medical signs that they should come see you for lower back pain? Maybe, things that we call like red flag symptoms, basically.
Right. One of the ones that I see a lot, not a lot, but I see enough, is progressive weakness of the leg, also called foot drop. If you're having difficulty walking, if your foot is dragging, obviously there are a lot of other medical conditions that could cause that, including multiple sclerosis and other things. I think it's very important to see a provider. We often discuss something called Cotter-Aquinas syndrome, which is incontinence of the bowel and bladder. The sensitivity and the specificity of that happening, a positive predictive value, it's not that great. So my point is, a lot of people with neurologic condition do not manifest with bowel and bladder incontinence. I think it's a good question to always ask. I think there are a variety of other conditions that could cause that, but that's one of the red flags that we often tell patients, at least see your doctor for, to make sure there's nothing else going on. And if you start having balance issues as well too, even though the spine is one of the reasons why you could have balance issues, we have to make sure it's not from other kind of serious conditions. So those are probably one of the couple of things that I always say, make sure you get checked out.
Yeah.
Obviously, last but not the least, we discussed something called nocturnal pain, nighttime pain.
Right.
Even though the chances of having cancer is extremely small with back pain, I can't say I have diagnosed probably several dozens of cancer during my practice. Last but not the least is just that severe, intractable 10 out of 10 pain. I'm very aware that 10 out of 10 pain is very different depending on who you talk to, but just being incapacitated because of the severity of the pain that you have, that's one of the things to say, you know what, even if it's nothing, let me just get checked out.
Sure.
So make sure there's nothing major going on.
Absolutely. And speaking of that, do you have sort of an algorithm in your mind when you see a patient come in, they're like, doc, I've got lower back pain. What comes to your mind immediately? Like, what are the questions? I mean, obviously like the history and physical, but is there a certain algorithm you have in mind when you see a patient?
Some that I think about. One is, I always ask him, patients don't, on athletes, they don't always like this. If you have one finger to point you where it hurts the most, where is it? And I understand there might be a region, but I kind of almost force my patients. There are some people that come in with back pain that point to the neck. There's some people with back pain that points to the thoracic spine. There's some people with back pain that point to the buttock. There's some people with back pain that points to the front of their hip. So you want to know that location. Then it's important to know, what are the triggers of the pain? What makes it worse? Is it crossing the leg that gives you pain in the front of the hip? That's more likely osteoarthritis. Is it pain that you have when you slip on the side of your hip? That's not probably coming from the back, even though it could be coming from the back. It's more greater trochanteric pain syndrome. Is it the pain that you have when you sit on the butt, and every time you sit, you feel like you got to raise your butt cheek up? That might not be coming from the back. That might be coming from the pelvic area, consistent with piriformis syndrome. Is it pain that you have with standing for a prolonged period of time versus pain you're having with sitting for a long period of time? If it's pain that you're having sitting or sitting for a prolonged period of time, more likely discogenic pain. Is it the pain that you have when you're brushing your teeth? Is it the pain that you're having when you're lifting or carrying your baby at the house? More likely discogenic. Is it pain that you have when you're standing for a prolonged period of time? They're more likely arthritis. So the location, one of the triggers, what makes the pain worse, it's important. Then I start talking about the radiation, or how far does it go? Where does it go to? I've diagnosed aortic abdominal aneurysms with people that complain of back pain. I've diagnosed kidney stones and fluid around the kidney area. Just making sure you have a clear understanding of the location, knows what the triggers are, what makes it better, what makes it worse. No doc, it's just constant 24/7. Then that cannot be mechanical low back pain. You got to think outside the box.
Yeah,
those are some of the things that I use to differentiate what type of pain or what course of pain it could be.
Got it. Is there something that sways you one way or another in terms of getting imaging or just relying on your physical exam to have a diagnosis?
So there's several studies that have shown when should we get imaging or not. If you have a history of motor vehicle collision, if you have a trauma, if you have progressive weakness, those are all reasons to consider getting one. If you've had this problem or condition for a prolonged period of time, the mechanism of injury that you've had it, those are the things that stir me one way or the other. So what I try to do is the duration. If they said, I just try to lift something and I just sprained my back, I'm probably not going to get x-ray because it's not needed. More importantly, because that does not change what treatment algorithm or what I have in mind. Mm-hmm. If they say I lifted, I twisted something shot down to my leg and I'm having weakness of my leg. It's the same mechanism of injury, but the presentation, the symptoms that they have is very different. Mm-hmm. That type of person are more likely to image. So my mantra is this: am I going to do something different if I get an imaging or not? If I'm not going to do anything different, less likely to get it. But if I have an ample amount of suspicion based on the history, based on the physical examination, mm-hmm. based on what we call medical comorbidities, meaning mm-hmm. what are the conditions that they have? Do they have a recent history of cancer? Am I concerned it might be metastasis of the cancer? Those are the kind of things that make me say, you know what, I'm going to get the imaging studies versus, I just lifted something, I tweaked my back. It doesn't go down my legs. I don't have any weakness of my leg. It's slowly getting better by itself. Mm-hmm. If that's the case, I'm probably less likely to get.
What role do you see physical therapy playing in lower back pain? I know it plays a pretty huge role, but to you, in your mind, what are you hoping to get out of that prescription? And when you do order physical therapy, do you like to add any additional stretches, exercises, strengthenings to your prescription for it for patients?
Therapy is extremely important, and I think the role of physical therapy is very, very, it could be seen different ways. Mm-hmm. Oftentimes, we have this fear of movement, and when you have pain, it's totally understandable. I think one of the purposes of therapy, in my mind, is depending on the severity of the condition, physical therapy can help you move. That's number one. The second thing is, even sometimes I do give patients home exercise program, but when you give them open exercise program, they don't know how well to do it. So home exercise program could be appropriate in some scenarios, but in other scenarios, home exercise program is better if they've gone to physical therapy once or twice to kind of perfect how they're doing those exercises. And as a result of that, they could transition to home exercise program better. The obvious fact is, in terms of, the resolution and the cure or the modification of the pain that they have. So, for example, if you have sciatica, what some people call lumbar radiculopathy, mm-hmm. there are different type of stretches, nerve gliding exercises that could loosen up that nerve and decrease the pain. But what I always tell people is one size does not fit all. So the prescription that says low back pain, in my humble opinion, should not exist. Mm-hmm. There are several reasons why you have low back pain. Is it coming from a strain? Is it coming from a sprain? Is it coming from a disc herniation? Is it coming from a stress fracture? Is it coming from a slip bone in your back? Is it coming from weakness of your legs? We have to have a very, very specific diagnosis. I often tell my patients, you need the right patient with the right condition to see the right doctor, to have the right treatment, to get the right results. Mm-hmm. If any of those does not align up, unfortunately, you don't get the good results that you want. So a very specific diagnosis. And sometimes you might not know what the diagnosis is. It's okay. That's why sometimes you get the advanced imaging studies. That way, you're kind of leading that patient the right direction to get the right treatment. So there's several other reasons, but those are probably some of the reasons why I do encourage my patients to do physical therapy.
With physical therapy, are there certain postural adjustments you recommend patients? It's kind of hard because, we have 15, 30 minutes with patients. We don't know how, maybe leaning over on a phone, maybe while at the computer, but are there specific postures you see causing back pain, or you tell people to perhaps stop doing, I guess?
Yeah. So one of the cases today is a 12-year-old, I believe he plays soccer, that I saw today. He's been dealing with knee pain for about 3 years. He landed funny 3 years ago, and he's been having pain. My examination, yes, it was tender to palpation around the quadricep tendon and the knee, but his hamstring was terribly tight. So when you have a history of hamstring tightness, that's one of the risk factors, not just for knee issues, but back issues as well, too. There's something called hyperlordosis, or simply put, an eye butt. If you have this curve in your back, and what it does is almost like tugging and pulling on your back muscles, as well as not allowing your hamstring to work as well as they should. So if you have extremely tight hamstring, if they have this curve of the back, those are one of the risk factors that could, from a posture, from a position, predispose them to back pain. So I always tell them, I'm happy to treat your back, but we have to take this poor range of motion and flexibility. I mentioned earlier about the correlation between the hip and the back. Oftentimes, arthritic hip in the older population, or simply put, impingements, has a good correlation with low back pain, including the sacroiliac joint. So making sure you examine the back, but also the hip, and checking from those flexibility or lack thereof is extremely important, because all of those could predispose them posture-wise to back pain.
Got it. How do you examine the hip tightness or the hamstring tightness?
Right. Oftentimes, I have a patient laying in a supine position, meaning just laying flat. I pull that knee up to about 90 degrees, called hip flexion, and I try to straighten out the knee to get it more straight, meaning the hip goes 90 degrees, but you want the knee to go almost the direction of 90 degrees.
Got it.
For a hamstring that's very tight, they wouldn't be able to straighten out the hip and the knee to go through the same line. It will be very bent. That's kind of how it identify and rates the severity of the hamstring tightness that the person has. Oftentimes, you can also have them sit all the way down, almost like the butt cheek is kind of falling off the chair. You could use that to check for quadricep muscle tightness as well, too. So you have him, the butt almost falling off the chair. You have him bring one leg or one thigh, one hip, pull it up. If there's tightness of what we call the quadricep muscles, usually the second one will come up as well, too. Versus if it sags down and lay flat on the bed, then you know those hamstring is not as tight.
Got it. And then moving on to treatment, can you touch on the oral pain medications you would recommend or prescribe for your patients?
That could be an interesting conversation to have, because I think there's a little bit of discrepancy between what the study shows and sometimes what we see.
Right.
Oftentimes, when you look at a lot of the studies, most of the anti-inflammatories that we prescribe has actually not been 100% proven to work. But when we do this in practice, we do see that it does help. Case in point, the one that commonly people ask for is anti-inflammatories. I think it all depends on the severity of your condition, but that's one of the medications that we use. Before I prescribe any anti-inflammatories, which is called non-steroidal anti-inflammatories, example is Aleve, Advil, diclofenac, meloxicam, naproxen, ibuprofen, on and off. I always ask them, do they have any history of ulcer? Do they have any history of GI bleed? Do they have any uncontrolled acid reflux? Or do they have any history of kidney or liver issues? If they don't, or not to any significant severity, I'm happy to prescribe that for them. If I see somebody that comes in, but they've had this chronic pain for several years, especially in the middle to older age population, the muscles can start being an issue, probably more than the condition. And oftentimes, I could prescribe a muscle relaxants. When I prescribe muscle relaxants, I always ask this question: are you taking any antidepressants? Because there's some muscle relaxants that has drug-to-drug interaction with others. I always ask them, are they taking a pain medication like tramadol that has drug-to-drug interactions with other muscle relaxants? I also ask, do they have uncontrolled high blood pressure? Because there's some muscle relaxants that have some interaction. I also ask, do they have difficulty sleeping at night, or do they have pain during the day? Depending on what answer they give to all those questions, there's a wide range of anti-inflammatories that I could prescribe. There's a group of medication called neuropathic agents. If people have things like sciatica type pain, I will prescribe that for them. But lastly, but not the least, there's something called medrol-dose-pak, which is prednisone. I always say too much of anything in life is not good. Too much of steroid, too much of prednisone is not good. But for a very short term, limited term, especially in the treatment of severe lumbar disc herniation or sciatica pain, those are probably a few of the medications that I prescribe.
And speaking of some of the, I think you even touched on it earlier, some psychological factors, perhaps not liking your job or, stress, anxiety. Do you see any of those contribute to lower back pain?
I always tell people sometimes there is reason to have back pain, but they're amplifiers of back pain. So if you have anemia, if you have thyroid condition, you do have back pain, but the level of back pain could quadruple or triple because of that condition. There are wide other things such as depression and anxiety. We know that that is a real thing that exists, but we also know it could amplify the amount or severity of which you feel that. So I think it's very important, not just for the metabolic standpoint, but from also the psychological stress, job satisfaction that we mentioned. Those are all the things that could contribute and make back pain worse.
Have you seen any advancements in the treatment of back pain since you've been in practice?
Yeah, there's a great evolution, and some things sometimes we'll learn from our mistakes. I've seen things range from therapy, medication, cortisone injection, but we know in some cases cortisone injection can be beneficial, but in some cases cortisone could be beneficial. One of the things that I'm passionate about is the field of orthobiologics, or simply put, regenerative medicine. NIH actually has a section that's dedicated towards regenerative medicine. Before I go in, we'll say, what is regenerative medicine and what is orthobiologics? Simply put, you're using part of your body to heal your body. That's the simplification of it. I will say the word regenerative medicine sometimes can be a little bit confusing because sometimes the notion is you have regeneration or regrowth or growth of different things that you have. That's not always the case. The field of orthobiologics evolved. Let's take, for example, an average person. Most will argue that disc herniation is one of the common causes of back pain. Oftentimes I tell my patients, you have a jelly donut, jelly in the middle, flour around it. When you have the flour around it, you have a small tear around the flour. And as a result of that, the jelly could go through the tear and squish out. Mm-hmm. Oftentimes, when you have that jelly that squishes out, you lose water, you lose protein, and the disc gets smaller and flatter. And sometimes, not all the times, they become more painful. When that happens, that tends to lead to a host of other conditions, including arthritis, ligamentum flavium hypertrophy, mm-hmm. lumbar stenosis down the line. The concept, for example, when we talk about the spine is, can we decrease inflammation? Can we decrease pain? Can we decrease the degeneration that happened in the disc that I just mentioned earlier? So there have been some successes with things like PRP injection that's been shown to, at the very least, help with the pain. Some studies have been shown also that stem cell injections, put in parenthesis, bone marrow aspiration concentration, especially when you have increased dose of what we call MSC cells, which is called medicinal signal cells, which old school back in the days, we used to call it mesenchymal cells, mm-hmm. has been shown to maybe slow down some of the wear and tear of that disc and will potentially lead to less worsening of that or less degradation of the disc, which hopefully will result into less arthritis, less stenosis in the future. The variety of other things that's been done, but that's one of the things that I'm very passionate about. There's a lot we don't know about it. When is the exact time to actually introduce that treatment? What are some of the bad guys out there doing that, quite frankly, does not align up with the world of orthobiologics? I often see a lot of people say they did this and that, and we know that's not the case. We know that's not what they do. We know that's not appropriate. We know that's not what it should be called. I think the field definitely needs some refining to do, but I think the field of orthobiologics and spine is one of the things that I'm very passionate about. I think the future is bright. I think we're going to get there. I think it just takes a little bit of fine tuning.
I interviewed Dr. Williams, and his clinic is strictly or primarily regenerative orthobiologic medications. And then how did you get involved in regenerative? orthobiologics.
Yeah, it's funny you say that. So like 11, 12 years ago when I was finishing on my fellowship, I think that was the year, or probably a little bit longer than that, Ainsworth, who used to play for Pittsburgh Steelers, caught this touchdown. And that's one of the ways they kind of, actually one of the key plays that they won Super Bowl. And so it became a more of a sexy appeal, like almost like, you get the PRP, you're going to catch the Super Bowl. Not to that degree, but to some degree. So it was sensationalized back then, about 13 years or so, give or take. So during my sports medicine fellowship, I did that on a couple of joints, including the knees. And as I kind of evolved in my sports medicine, meaning doing in the peripheral joints, such as the knees, the shoulders, depending on what body part, I started exploring the idea about doing that in the spine as well, too. And when I read the literature, I kind of visited a couple of colleagues to kind of see what the paradigm or ways or approaches. I attended a couple of courses and kind of started doing it on my own. There's been excellent results in the peripheral joint literature. We often get asked, what's the level 1 studies? I encourage my peers and the general public to get educated, because there are level 1 studies that suggested that. Our goal is to kind of translate that level 1 studies to other parts of the body. But that's kind of how I got into it. Just kind of started doing other body parts, kind of got more familiar with it, started doing the spine, and I've had a good amount of success with it.
Awesome. Are there any success stories, patient testimonials you can share with us that come readily to mind when it comes to back pain? And that can be sort of treatments from you did nothing and there was no hope, but they got better somehow, or all the way to sort of the most invasive things that you do, whether it be like BMAC, like you were mentioning, or any spine procedures that you've done.
I think one of the reasons why I did a combination of both fellowships was not necessary for the athlete, but being able to kind of have all the skill set to treat a patient. So I could remember a 17-year-old athlete that came to see me with low back pain that was just looking forward to getting that scholarship, because that's what the parents needed for him to get that college scholarship. You know, trying a couple of injections, and sometimes not even trying the injections on him, just going through a rehabilitation course. For that particular 17-year-old I was referring to, I did one epidural injection with corticosteroid injection. Went through a bunch of other things. Obviously, we did therapy first. We tried some other things, and he was able to get that scholarship. To a 50-year-old or 45-year-old male that loves CrossFit. That's how he manages anxiety. That's how he manages depression. That's how he stays fit. And being able to, in that case, do just, some back bracing, as well as some PRP injection, actually, a couple of them, at a couple of levels, being able to kind of return to what they need to do. To that 75-year-old grandma that just wants to be able to play with their grandchild. That just wants to be able to be a nanny that takes care of their kids. Those are the things that bring joy to me and makes me very happy about what I do.
And then lastly, to wrap it up, you kind of already mentioned this earlier, but what advice would you give to people currently dealing with lower back pain right now?
Yeah, I think my advice is getting a clearer understanding of what it is, understanding all back pains are not the same. If you have it during pregnancy, it's going to be something that's very short term. If you have an autoimmune condition, that's one of those modifiers of pain, making sure we're not just treating the low back, but we're treating those other conditions that amplifies it. Knowing how to modify your activities, you don't have to stop everything, but having a better understanding of what your condition is, knowing the things that makes it worse, knowing the things that makes it better, having that middle ground of some of the things you are able to do. I think there are several books out there that just allows you to understand the back pain and understand that your life does not have to stop. Sometimes a few people might have to deal with it every now and then, but the reality is the vast majority of people that have back pain, it tends to be a one-time situation. So all size does not fit all.
Right.
Majority of people is a one-time situation. Less than 30% will have it consistently. I think having a good provider or having a good, to be frank with you, podcast like you have over here gives people an opportunity to understand things better and understand there's hope for them. There's resolution for this in some cases.
Awesome. Dr. Olufade, thank you so much for your time. I really appreciate you being on.
My pleasure.
All right.
Thanks for having me, Derek.
Thanks, sir.